half the people doing pelvic floor exercises right now are, well, they're actively making their incontinence worse.
Yeah, it's actually a pretty alarming statistic.
Right. And to fix that frustration, you've got clinics literally selling these illegal space-age cellular injections. So, welcome to the deep dive.
Thanks for having me.
Our mission today is to look at this massive silent epidemic and, really answer a question that is currently just tearing through the aesthetic and medical communities.
And that question is, are intimate exosomes used to treat pelvic floor dysfunction?
Exactly. Are intimate exosomes used to treat pelvic floor dysfunction? We really need to get to the bottom of this because stress urinary incontinence, or SUI, it's not a niche issue at all.
No, not even close. Up to like 46% of adult women in the U.S. experience this.
46%. That's huge.
Right. And it costs the healthcare system over $12 billion annually.
Wow. $12 billion. But, as a patient, you're left navigating this really bizarre landscape.
Yeah, you're basically caught in the middle.
Right. Because on one hand, you have this highly effective, free physical therapy routine that, like we said, millions of people are performing completely backward.
Which we will get into later because it's fascinating.
Absolutely. And then on the other hand, you have providers marketing these futuristic serums that honestly sound like science fiction.
Well, to sort of navigate that landscape, we are pulling from a really diverse stack of sources today.
Yeah, we've got a lot of ground to cover.
We do. We're looking at some pretty dense molecular research from Frontiers, as well as the Royal College of Obstetricians and Gynecologists.
Right. And then we're checking the reality of clinical aesthetics through insurance guidelines from Enhanced Insurance over in the UK.
Exactly. And we're going to anchor all of that with the actual clinical physiotherapy protocols from the NHS and the British Association of Urological Surgeons.
So let's just start with the biology.
Yeah.
Because, when we think of a leak, we usually think of a mechanical failure, right?
Like a pipe bursting.
Yeah, or like a muscle just getting totally stretched out. But the Frontiers research paints a picture that is, microscopic and honestly incredibly murky.
Yeah, it's way more complex than just a weak muscle.
Yeah.
What is actually failing in the pelvic floor during SUI is a two-part system.
Okay, two parts. Break that down for me.
You have to think of it as a hammock combined with an active seal. So the hammock is your passive support.
Just literally holding things up.
Right. It's this complex interwoven layer of muscles, ligaments, and connective tissue. It stretches horizontally from your pubic bone at the front all the way to your tailbone at the back.
Okay, so it cradles your bladder, the bowel, your uterus.
Exactly. It's the structural floor of the abdomen, just doing the heavy lifting against gravity.
That makes sense. But what about the seal part?
So that passive support is crucial, but then you have the active seal. The lower two-thirds of your urethra relies on this neurally mediated closure mechanism.
Meaning nerves control it.
Right. So when intra-abdominal pressure suddenly spikes, like if you sneeze or if you laugh or even just lift a heavy box, the hammock is supposed to hold the organs firm.
Okay.
And simultaneously, the local nerves are supposed to fire instantly to tighten that urethral seal.
So SUI happens when that internal bladder pressure just, overwhelms the seal and you get a leak.
Exactly. But the research shows this isn't just about the hammock physically tearing from, say, trauma.
Right. You mentioned it's molecular. What's actually happening to the tissue?
The breakdown happens literally within the extracellular matrix. That's the biological scaffolding holding your tissue together.
Yeah.
In SUI patients, researchers are observing this abnormal metabolism of collagen and elastin.
Wait, so the threads of the hammock are literally dissolving?
Yeah, basically. The tissue loses its tensile strength because of the collagen loss, and then it loses its snapback resilience from the elastin loss.
Oh, wow. So it just stays stretched out.
Right, and the crazy part is the body is actually doing this to itself. SUI patients show highly elevated levels of MMPs.
Wait, what are MMPs?
Matrix metalloproteinases.
Okay, I am definitely going to need an analogy for that one.
Well, think of them as a demolition crew. Their normal job is to clear away old, damaged collagen so new tissue can be built.
Oh, I see. So normally they're helpful.
Exactly. But in SUI, the demolition crew goes into overdrive. They actively degrade the structural collagen way faster than the body can even replace it.
That sounds disastrous. And the sources also mention something called calpain-2 acting alongside that demolition crew.
Yeah, calpain-2 is a neutral protease. To put it simply, it's an enzyme that acts like molecular scissors.
Molecular scissors? That doesn't sound good.
No, it's not. It gets activated when calcium levels inside the cell spike abnormally high. And when that happens, it just starts chopping up at the myofibers in the muscle and the elastic fibers in the tissue.
So you literally have this active, ongoing molecular dismantling of your own structural support.
Yep, it's actively chewing up the hammock.
Okay, so the scaffolding is being digested by enzymes. That explains the hammock failing. But what about the seal?
The active nerve response, right?
Yeah, the one that snaps the urethra shut when you sneeze. That leads me to something in the childbirth research that just seemed completely backward to me.
Yeah. You're talking about the BDNF dilemma. It is honestly one of the most frustrating biological compromises in the entire human body.
Walk me through this, because BDNF stands for brain-derived neurotrophic factor, right?
That's right.
And as I understand it, this is a protein that is absolutely crucial for the survival and growth of nerves.
Yes, it is a phenomenal nerve healer.
Right. So during a difficult childbirth, a woman can experience severe trauma to the pudendal nerve, which controls the pelvic floor.
Along with physical trauma to the urethral sphincter muscle itself, yeah.
So logically, you would think the body would just immediately flood the pelvic floor with BDNF to heal that damaged nerve.
That would totally be the logical assumption.
Yeah.
But the body actually does the exact opposite. It intentionally downregulates, like it actively starves the area of BDNF after this kind of pelvic injury.
Wait, why? Why would the body actively turn off its own nerve-healing protein when the nerve is damaged?
Because it's trying to save the muscle.
Oh!
See, BDNF is fantastic for the nerve wire itself, but it severely impairs the formation of neuromuscular junctions.
Those are the communication bridges, right, where the nerve plugs into the muscle fiber.
Exactly. And BDNF also stalks myoblasts, which are the early stage cells that repair muscle for maturing.
So let me get this straight. The protein that heals the nerve wire actively prevents the wire from plugging into the engine.
Yes. And it stops the engine from being rebuilt at all.
That is wild.
So the body is faced with an impossible choice after pelvic trauma. Does it flood the area with BDNF, healing the nerve wire perfectly but leaving the muscle permanently disconnected?
Right.
Or does it lower the BDNF, allowing the muscle fibers to heal and the junctions to form, but leaving the nerve's regenerative response permanently stunted?
Wow. And it chooses the muscle.
Right.
It lowers the BDNF to let the tissue heal, but just completely sacrifices the nerve.
Which leaves you with a compromised seal. You might have relatively intact muscle tissue down there eventually, but the nerve signal telling it to snap shut during a sneeze is delayed or permanently weakened.
Which brings us to the massive question dominating our sources today.
The exosomes.
Right. If the body's natural response is to let enzymes digest the collagen and intentionally stunt the nerve repair, can we override that? Like, can we command the body to rebuild both?
Which is the exact promise being marketed so aggressively right now.
So are intimate exosomes used to treat pelvic floor dysfunction?
To really understand the hype, we have to contrast them with stem cells.
Yeah.
For years, injecting whole stem cells into damaged tissue was seen as, the ultimate regenerative therapy.
The idea being that you inject stem cells, they recognize the damage, and they just turn into fresh muscle or nerve cells.
Exactly. But transplanting whole cells carries significant risks. Your immune system might reject them. They might multiply uncontrollably.
Right, tumors and stuff.
Yeah, or they might cause vascular obstruction. Stem cells are physically large. If they clump together, they can literally clog the local blood vessels and cause tissue death.
Oh, wow. So how do exosomes bypass that risk?
Because they aren't the whole cell. If the stem cell is the factory, the exosome is just the text message the factory sends out.
I love that analogy, just a text message.
Yeah, the formal term in the research is exocytosis. The stem cell takes specific internal instructions like proteins, lipids, mRNA, packages them into a tiny membrane bubble, and pushes that bubble out into the surrounding fluid.
They're just spitting out these tiny instruction packets.
And they are microscopic. We're talking a diameter of just 30 to 150 nanometers.
Tiny.
Right. These little messenger vesicles float over to the damaged pelvic floor cells, merge with them, and just deliver a new set of instructions.
Bypassing the whole cell risks.
Exactly, because they have no nucleus, they can't multiply, and they're way too small to clog veins.
And according to the Frontier's preclinical data, those microscopic text messages are incredibly effective in animal models.
They really are.
Yeah, scientists are isolating exosomes from fat tissue, from nerve-supporting Schwann cells, even from urine-derived stem cells, and injecting them into rats with SUI.
And the animal results are remarkable. The exosome instructions literally tell the rat cells to regulate those destructive MMP enzymes.
They halt the demolition crew.
Yes. They halt the collagen demolition, they enhance skeletal muscle growth, prevent further tissue degradation, and ultimately restore the function of that urethral seal.
I mean, I completely see why aesthetic clinics are jumping on this. You have a risk-free, tiny biological messenger that tells your pelvic floor to stop digesting its own collagen and rebuild itself.
It sounds like a miracle cure.
It really does.
Yeah.
For a condition affecting nearly half the female population.
But this is precisely where we hit the regulatory wall. We are moving from the controlled environment of an animal lab to the legal reality of modern clinics.
Right, because we reviewed the data from Enhance Insurance in the UK, which provides coverage for cosmetic and aesthetic practitioners.
And they are issuing a massive warning to their clients.
Yeah, clinics are actively marketing exosomes for intimate rejuvenation, injecting them directly into patients. But the UK's regulatory agency, the MHRA, classifies injected exosomes as medicinal products.
And under that classification, injecting them into the skin, under the skin, or into a vein is strictly prohibited.
Period.
Period. There are currently 0 exosome-based injectables that have UK marketing authorization. None.
But if they're just safe little text messages, why is the regulatory agency treating them like illegal contraband?
Because of where the text messages come from. The MHRA has banned all human-derived exosomes. You have to consider the mechanism of extraction here.
Okay, meaning what?
If you're taking cellular material from human donors, even just the messenger vesicles, you risk transmitting blood-borne pathogens, or obscure viruses,
I see.
or rogue genetic material that could trigger unwanted immune responses, or even oncogenic cancer-causing mutations in the receiver.
So they ban human-derived exosomes entirely. But the insurance data mentions that plant or animal exosomes are allowed.
That's right.
Why allow one and not the other?
Well, plant and animal exosomes don't carry human diseases, so the transmission risk drops. But legally, even those non-human exosomes can only be used topically. You absolutely cannot inject them.
Topically, meaning you can only just rub them on the surface of the skin.
Usually after a procedure like microneedling to help soothe the epidermis. But consider the biological logic here.
Okay.
Rubbing plant exosomes on your skin might reduce redness, but a plant's cellular text message does not contain the mRNA instructions to rebuild a human urethral sphincter muscle.
So any clinic offering to inject exosomes to cure your pelvic floor dysfunction is not only using the wrong biological material, they're operating entirely outside the law.
And according to the insurance guidelines, they're likely voiding their medical malpractice coverage.
That is terrifying.
It is. If they cause an infection or nerve damage with an illegal injection, the practitioner is unprotected and the patient has absolutely no recourse.
Which honestly makes the final detail from the Frontiers paper the most sobering part of this entire deep dive.
Yep.
We saw all those amazing results in rats. But how many clinical trials have actually proven exosome efficacy for SUI in living human patients?
0.
Seriously, not a single human trial.
The curative effect on clinical patients simply has not been examined yet. The paper is explicit, further research is needed, there is no proven clinical link.
Wow.
So to answer the core question, are intimate exosomes used to treat pelvic floor dysfunction? The answer is they absolutely shouldn't be, not yet. It is premature science being sold as a current cure.
We can't biohack our way out of this with unregulated illegal injections.
No, we can't.
So if the futuristic cellular therapy is off the table, what are doctors actually doing right now to help people with degraded collagen and compromised pelvic nerves?
Oh, if we look purely at the cellular therapies that are legally in clinical trials, researchers are using actual muscle-derived stem cells, or MDSCs.
Right. The Frontiers source had a breakdown of this. They basically take a muscle biopsy from the patient, extract the stem cells, grow them in a lab, and inject them directly into the urethral sphincter.
And a review of 11 studies showed a median postoperative improvement rate of 77% for SUI patients receiving these muscle stem cells.
A 77% improvement is massive. But this isn't exactly a walk-in aesthetic procedure, is it?
Far from it. The initial muscle biopsy is painful. MDSCs don't multiply very well in the body, so they have to inject incredibly high doses of cells.
Which means repeated procedures.
Exactly. Repeated painful procedures. And the most discouraging part is that the treatment efficacy declines significantly over time. As the injected cells die off, the leaks return. It isn't a permanent structural fix.
So stem cells are a painful, temporary maybe, still in clinical trials, and exosomes are an illegal no.
Right.
Which brings us to the undisputed, heavily researched champion of pelvic floor treatment. It requires no lab, no syringe, and absolutely no risk of voiding your doctor's insurance policy.
Pelvic floor muscle training, clinical physical therapy.
I know that sounds incredibly unglamorous after talking about nanometer-sized cellular text messages.
It does.
But the data from the NIHR pre-Proles trial is undeniable. They took women experiencing minor prolapse symptoms and guided them through targeted muscle training.
And simply performing the exercises correctly reduced the need for surgical intervention by 8%.
It improved symptoms, it halted the severity of the prolapse, and provided immediate relief. But there's a massive catch.
There always is.
We looked at the clinical guidelines from NHS Lothian, and they highlight a terrifying statistic. 50% of women who are only verbally taught how to do pelvic floor exercises are doing them completely wrong.
Half the patients. And the danger isn't just that the exercises won't work. The NHS warns that doing them incorrectly can actively cause more harm.
Right. If you are listening to this in your car or sitting at your desk, let's make sure you aren't in that 50%. The most common mistake is bearing down, like pushing outward, like you're trying to empty your bowels.
Yeah, and if your internal hammock is already weakened by enzymes in childbirth and you actively push down on it repeatedly,
You're subjecting the compromised tissue to even more strain.
exactly. You are actively widening the gap and making the incontinence worse. This is why national guidelines strongly urge referral to a specialist women's health physiotherapist.
So they can do a physical assessment to ensure your brain is actually communicating with the correct muscle fibers.
Precisely.
Let's break down the clinically accurate method from the British Association of Urological Surgeons, or BAUS, just so people know exactly what the correct machinery feels like.
The first step is complete isolation. Sit or lie down comfortably. You must consciously relax the muscles of your thighs, your abdomen, and crucially, your buttocks.
Okay, why the buttocks?
Because if you're clenching your glutes, you are engaging massive external muscles that actually encourage a downward push.
Got it. So no squeezing the butt cheeks or the stomach, just the pelvic floor.
Right. To find that specific muscle, BAUS suggests 2 visualizations. First, tighten the ring of muscle around the back passage as if you're desperately trying to control passing wind.
Okay.
Second, imagine you are passing urine and you need to stop the flow midstream.
I actually noticed BAUS explicitly says you can test this midstream stoppage on the toilet to find the muscle, but you must only do it once a week maximum. Why is that?
Because if you routinely stop your urine flow every time you use the bathroom, you confuse the neurological reflexes governing your bladder.
Oh, that makes sense.
Yeah, it leads to incomplete emptying, which causes urinary tract infections. Testing it on the toilet is just a diagnostic tool to locate the muscle. It is not the workout itself.
Okay, so you're sitting down, legs relaxed, glutes relaxed, and you found the muscle. What is the actual clinical routine to rebuild the seal?
You tighten and draw those muscles UP inside you. The upward lift is essential. You hold that contraction for 5 to 10 seconds. Then you must release the muscles slowly and let them fully relax.
The slow release makes sense, like lifting a dumbbell at the gym, right? The slow controlled release is where you build strength.
Yes, exactly. You're targeting the slow twitch muscle fibers that provide the endurance to keep the hammock taut all day long. You do 8 to 10 of those slow, controlled holds, but that's only half the routine.
There's more.
Immediately following the slow holds, you perform 10 short, fast contractions, pulling the muscle up rapidly and instantly letting go.
Why the fast flicks?
To target the fast-twitch muscle fibers. Those are the fibers responsible for the active seal. When you sneeze, you don't need endurance. You need an instantaneous, explosive contraction to snap the urethra shut.
Oh, so the fast flicks train that specific neural pathway.
Exactly.
So it's 8 to 10 slow holds for the hammock and 10 fast clicks for the seal. And you repeat that entire routine 4 to 5 times a day, every single day.
It requires immense consistency. The BAUS guidelines note you probably won't see any improvement for several weeks, and it often takes months of daily work to achieve maximum benefit.
That's a serious commitment.
It is. And once you recover control, you drop down to twice a day, every day, for the rest of your life to maintain the structural integrity.
Which really brings our deep dive full circle today. We started at the microscopic level, looking at how enzymes literally digest our internal scaffolding and how the body sacrifices nerve connection to heal muscle.
And we explored the theoretical promise of exosomes, the idea that we might one day inject cellular text messages to command the tissue to rebuild itself perfectly.
But we also face the regulatory reality. Human-derived exosomes carry way too many risks to be legal in the UK, and there are exactly 0 human trials proving they cure pelvic floor dysfunction.
So we land safely on the proven reality of physical therapy. You have to put in the mechanical work to retrain the slow and fast twitch fibers, because you simply cannot biohack your way out of a structural collapse with an illegal syringe.
And that leaves us with a really vital shift in perspective. We're living in an era where we constantly look outward for the effortless fix.
We really do. We want the invisible molecular cure injected in a 5-minute aesthetic appointment.
Yet we entirely neglect the mechanical maintenance of the incredible biological systems we already possess. So, before you go searching the internet for an unproven, unregulated cellular messenger to rebuild your internal hammock, take a moment and ask yourself, have you actually mastered the machinery you already own?